Welcome to this Step 3 review on supportive oncology and end-of-life care, brought to you by Roadmap to Residency. This topic is a favorite on the exam because it lives where medicine meets judgment. The test wants to know whether you can control a symptom, choose the right medication, and recognize when the goal of care has shifted from cure to comfort. We are not reteaching the whole subject today. We are showing you how these stems are built and how to attack them. Find the underlying content in the palliative care and oncology sections of your review book and question bank. Here is our plan. First, cancer pain, where the test rewards the right drug at the right dose. Second, nausea and vomiting, where the stem names the mechanism and the drug follows from it. Third, end-of-life symptoms, where the goal shifts from fixing disease to relieving suffering. And fourth, hospice referral. We will work through 4 practice questions and explain why every choice is right or wrong. This assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Cancer pain stems look long, but they are built from 2 clues. First, find the pain word, because those adjectives are chosen deliberately. Burning, shooting, or tingling pain running down a limb is neuropathic, pushing you toward gabapentin, pregabalin, or duloxetine rather than more opioid. Deep, aching, well-localized bone pain points toward a non-steroidal anti-inflammatory drug, or radiation for a single painful spot. Dull, constant, poorly localized abdominal pain is visceral and responds to opioids. Second, ask whether the question is about scheduled or rescue dosing. Pain present most of the day needs a long-acting opioid on a schedule, with a short-acting opioid for breakthrough. The classic stem gives a patient on a long-acting agent using many rescue doses daily. That is not a reason to switch drugs. It is a reason to raise the scheduled dose, and the breakthrough dose rises with it. Now, the opioid traps, where good students lose easy points. First, in cancer pain, an opioid has no ceiling dose. The right dose is the one that controls pain. So any choice that withholds, lowers, or delays an opioid out of fear of addiction, tolerance, or respiratory depression in a tolerant patient is a distractor. Remember that sedation reliably comes before respiratory depression, so a comfortable, awake patient is not on the edge of disaster. Second, always start the bowel regimen. Opioids cause constipation from the first dose, and unlike nausea and sedation, patients never become tolerant to it. Whenever a stem starts an opioid, a stimulant laxative such as senna belongs in your answer. Watch for bulk-forming fiber as a distractor because in a slow gut, it makes things worse. Nausea fades, sedation fades, constipation never does. Nausea questions are mechanism questions in disguise. The stem always names the cause, and the medication follows from the why. So do not memorize a flat list of drugs. Learn which receptor each cause turns on, and the answer picks itself. Know the 4 patterns you will actually see. Nausea on the day of chemotherapy calls for a serotonin blocker such as ondansetron. Nausea appearing days afterward is delayed nausea and calls for a prepitant. Nausea with early fullness and bloating from slow stomach emptying calls for metoclopramide. And nausea from raised pressure inside the skull, often with a morning headache, calls for dexamethasone. Finally, watch the contraindication trap. Metoclopramide is a lovely answer for slow emptying, but it becomes wrong the moment the stem mentions a complete bowel obstruction because a promotility drug in a blocked gut causes harm. There, look for octreotide instead. The test loves that exact switch. Our first practice question. A 62-year-old man with widespread prostate cancer in the bone takes long-acting morphine twice daily with short-acting morphine for breakthrough. His pain is a 7 out of 10 most of the day, and he has needed 6 rescue doses daily for a week. He is alert, comfortable at rest, his breathing rate is normal, and he takes senna. What is the most appropriate next step? Notice what the stem is doing. It tells you the pain is present most of the day, counts his rescue doses, and goes out of its way to say he is alert with a normal breathing rate. Every detail is there for a reason. Choose your answer. Let us break this down. Pain most of the day, plus frequent breakthrough dosing, tells you one thing. The scheduled dose is too low, and look how the stem cleared your path. Alert with a normal breathing rate removes any safety concern, and senna removes constipation as the issue. So apply the rule. When a patient needs frequent rescue doses and is not sedated, raise the scheduled long-acting dose and raise the breakthrough dose with it. The answer is to increase the scheduled long-acting morphine dose, Now the wrong answers. Stopping morphine for a non-steroidal drug alone abandons control of severe pain. Calling this the maximum safe dose is false, because opioids have no ceiling in cancer pain. And referring him to a chemical dependency program mistakes uncontrolled pain for addiction, the trap this exam plants again and again. A patient asking for more medication because his pain is a 7 out of 10 is not showing addiction. He is showing undertreated pain. Our second question, and it is pure mechanism. A 58-year-old woman with pancreatic cancer has nausea for 2 weeks. She feels full after a few bites and vomits undigested food in the evening. Her last chemotherapy was 6 weeks ago. Her abdomen is soft with normal bowel sounds, she is passing gas and having bowel movements, and imaging shows no obstruction. What is the most appropriate treatment? Notice the details you are being fed. Fullness after a few bites. Undigested food hours later. Chemotherapy far too remote to blame. And a stem that deliberately rules out obstruction. Each one steers you toward a mechanism. Choose your answer. Name the mechanism first. Early fullness plus vomiting of undigested food hours after eating is the exact language of a stomach that empties too slowly. And look at the work the stem did for you. It dated the chemotherapy to 6 weeks ago, so you cannot blame the drugs. And it cleared obstruction, which is what makes a promotility drug safe. Metoclopramide speeds emptying, and it is the answer. Now why the others fail? Ondansetron treats nausea on the day of chemotherapy, and hers was 6 weeks ago. Aprepitant treats delayed nausea in the days right after chemotherapy, not weeks later. Dexamethasone would be your answer for nausea from raised pressure inside the skull, and there is no headache or neurologic finding here. Notice that every wrong answer is a real drug for a real mechanism. They are simply right drugs for the wrong patient. That is how these questions are built. Now the mental shift the end-of-life section is testing. Treat the symptom, not the number. At the end of life, this exam stops rewarding workups, so when a STEM describes a dying patient, any choice that orders a scan, draws laboratory studies, or chases a diagnosis is a distractor. The right answer relieves the symptom in front of you. The highest yield example is breathlessness, treated with low-dose opioids, and that stays true even when the oxygen level is normal. If the STEM gives you a normal oxygen level and still describes a patient struggling to breathe, that is your signal to reach for the opioid, not the oxygen. Then know the 3 classic symptoms. Noisy breathing from secretions distresses the family, not the patient. Treat it with repositioning and glycopyrrolate if a drug is needed. Deep suctioning is the trap because it is uncomfortable and does not help. Agitated confusion is treated with haloperidol. Breathlessness is treated with an opioid. Our third question. A 70-year-old man with widespread lung cancer is at home on hospice. His family reports he appears breathless and anxious with any movement. He is awake and speaking in short phrases. His oxygen saturation is 96% on room air, and his lungs are clear. His goals of care are comfort-focused. What is the most appropriate next step? Look at what this STEM handed you. A saturation of 96%, clear lungs, and goals of care stated plainly. When a STEM states the goals out loud like that, it is not making conversation. It is telling you which whole category of answers to eliminate. Choose your answer. Separate the sensation from the number. Breathlessness is something the patient feels, and it is not the same as a low oxygen level. This man feels breathless at a saturation of 96%, so oxygen has nothing left to correct. Low-dose opioids blunt the sensation itself, and that is the standard treatment. The answer is to start low-dose oral morphine. Now the wrong choices, which all make the same mistake in different costumes. Scanning the chest for a clot chases a diagnosis he would not treat and conflicts with his stated goals. High-flow oxygen cannot improve a saturation that is already 96%, and all it accomplishes is strapping a mask onto a dying man's face. Transferring him to the emergency department abandons the comfort-focused plan his family chose. Every distractor does something to the patient rather than for the patient. Our fourth and final question. A 68-year-old woman with widespread pancreatic cancer has progressed through 2 lines of chemotherapy. Her oncologist estimates her life expectancy is less than 6 months. She spends more than half the day in bed, has lost weight, and tells you she wants no further chemotherapy and wishes to stay home. What is the most appropriate next step? Your choices are to refer to hospice care, to offer a 3rd line of chemotherapy, to refer to hospice only once she is in her final days, or to tell her hospice means giving up and continue treatment. Notice the STEM has quietly handed you every criterion you need. Choose your answer. She meets every hospice criterion, and the STEM gave them all to you. Life expectancy under 6 months, disease progressing through 2 lines of treatment, declining function since she is in bed more than half the day, and a clear wish to stop treatment and stay home. The answer is to refer to hospice care. Offering a 3rd line ignores what she just told you. Referring only in her final days is the most common real-world error, because most of the benefit comes from referring earlier. And calling hospice giving up is false and disrespects her choice. So, pulling it together. For pain, find the pain word, decide whether the question is about scheduled or rescue dosing, and never mistake uncontrolled pain for addiction. For nausea, the STEM names the mechanism and the drug follows. At the end of life, treat the symptom rather than the number. And for hospice, when life expectancy is under 6 months and the patient wants comfort, refer now. Read the palliative care and oncology sections of your review resource, then drill these patterns in your question bank under timed conditions. Visit roadmaptoresidency.com for expert tutors and residency advisors who can build you a personalized plan. If this helped, please like and subscribe. Good luck on your exam, and we will see you in the next video.